I'm Professor Zeba Aziz from Lahore, Pakistan, and I'm a professor of medical oncology. And hopefully this should be a last problem from me. We are going to start for the international CMF discussion, which has raised the bar of CML management and education for all of us living, especially in the third world countries, where education is very difficult. But with the iCMLf, which has started our education, and they're sending people, younger physicians abroad, doing a lot of stuff. It's an extremely important support for us. And with this, the management of CML is improving every day. In the last 12 to 14 years, we've seen a marked improvement despite, and especially for our younger physicians who have not even been trained because of the constant education by the iCMLf for us. So education for the physician is a very important thing. And they, at the same time, it's not only teaching the third world and the global research, it's also doing iCMLf Genomics Alliance. We have a TFR Alliance, where you put the patients on treatment-free remissions very scientifically. As a result of which, we don't have a lot of problems and we are getting very good results. Pediatric CML is another area in the low middle income countries which needs a lot of attention. And because of iCMLf, we have seen a marked improvement in the pediatrics management of chronic myeloid leukemia. Less and less patients are being transformed to the acute phase and are presenting early in the chronic myeloid phase. Currently, the iCMLf is looking at hepatitis B and CML and survey of the practice. I feel, Arlene, we also need to do hepatitis C, which is a very common problem in the developing countries. Today, we are going to have two very important discussions because dose reduction as a pathway to treatment-free remission, is it possible or not? And the second session will be on subsequent treatment-free remission attempts. Now, these are very important for us. So without any ado, we'll start on the first discussion, which is dose reduction as a pathway to treatment-free remission. And Dr. Akhil Biswas will present from Bangladesh. He is a hematology and bone marrow transplant unit. He works in the hematology and bone marrow transplant unit and is from Dhaka Medical College. He's one of the pioneer hematologist oncologists in Bangladesh and has done a lot of work for the public sector hospitals and even in the private sector. I welcome Dr. Biswas for his first presentation.
Thanks, Deva, for your kind words, and thanks to iCMLf for the discussion of such a fantastic issue, which is important not only for the South Asia, and I think definitely for the whole world who are treating for CML. And it is after TFR, it is another strategy. It is probably finding a newer strategy, maybe more effective, or maybe more acceptable through the dose reduction. Okay, so evidence are in early evolution regarding the dose de-escalation or defining efficacy of lower dose PKI. And minimum effective dose or optimal dose de-escalation of PKI has not been established except for ponatinib. And reducing dose of PKI after optimal response may be an strategy to minimize long-term toxicities of PKI. And the strategy and to define optimal condition for dose de-escalation of PKI as bridging to TFR, or at least finding an effective minimum dose of PKI, may help more successful TFR and minimize long-term toxicity. And idea of dose de-escalation is actually stemming quite recently, and from two data sets from UK, one prospective and another retrospective done by research. Clark and his team in the Destiny trial found that the chance of maintaining TFR at 2 years after MR4 achievement, it was 72%, and another retrospective analysis found that it was almost similar, 74.1% was able to maintain TFR after 2 years when the TFR was attempted after dose reduction. And importantly, MR3 was maintained in 91.9% of patients with reduced dose of PKI, and remaining 8.1% was able to, almost all of them are able to regain MR3 when resume the higher dose of PPI or alternate PPI. And another two data sets from the China, more recently, one presented in year 2023 and another presented published in Cancer 2024, it came with almost similar result that reduced dose imatinib or PPI had outcome comparable to standard dose in terms of major molecular remission failure-free survival, MR4 failure-free survival, and cumulative incidence of MR4 and MR4.5 and eligibility to TFR. And chance of maintaining MMR beyond 12 months of TFR was in 66%, who going to TFR to reduce dose, and for less than 50% in the standard dose imatinib. However, reduced dose group showed lower chance of maintaining stable MR4 and higher MMR failure when dose reduction in older age or dose reduction was attempted before MR4 achievement. And in summary, we can tell that standard dose with standard dose imatinib, the chance of TFR in 2 years was less than 50%. However, when the TFR was attempted through dose de-escalation, it was more than 70%. And I will go to present my two cases. So, case one was a 29-year-old software engineer who was currently now 33 years. Incidentally, leukocytosis led to CML diagnosis in June 2021. He was both ELTS and glucose risk score was low, and no additional chromosomal abnormality was found. Comorbidity was dyslipidemia and recurrent hidradenitis, which was treated successfully within first few months. And generic imatinib 400 milligram was started on June 18, 2021. Imatinib was well tolerated without any hematological or other organ toxicity. And complete hematological remission was gained in early 4 weeks, and molecular response was at 3 months, it was 0.8586. At 6 months, he gained major molecular remission, same as in 12 months, and at 15 months, he gained deep molecular remission MR4, and at 18 months, he was in deep molecular remission MR4.5. And the same MR4.5 was maintained, found in subsequent 4 assets in 6-month interval till December 2024, and TFR was offered, but he denied fearing molecular relapse because he was tolerating imatinib very well. However, he loved the idea of gradually reducing the dose of imatinib, and the dose was reduced to 300 milligram in January 2025. And the key question are what will be the frequency of molecular monitoring and interval to further do dose de-escalation step, and extent of dose de-escalation before TFR. Will it be 200 milligram or 100 milligram, or it will be patient choice? Or approach in case of loss of deep MR during dose de-escalation? Will you continue the lower or minimum effective dose, able to maintain major molecular remission or deep molecular remission, or resume the full dose? Or what will be the frequency of monitoring during TFR if we go through the dose de-escalation? Will it be similar like 1 month in first 6 months, or 2 to 3 months in next 3 months, or 6 months, or it would be a bit more or less frequent scan? And welcoming for the discussion about the first case.
Putting up your second case, I'd like to ask Professor Apperley to comment on the questions you've asked, and what are her opinions about it, so that we can all benefit. And I think it is a good way to have a dose reduction, because it helps us decrease the cost and make the treatment more cost effective.
So thank you very much for this nice case of somebody who actually is responding incredibly well, so is in a very good position. So I understand why you put up this case, but I just want to draw a very clear distinction between the two groups of patients who might wish to address dose reduction. One is clearly patients who are responding but have a lot of toxicity, and they would want to see whether they could continue to have such a good response, but on a lower dose of the drug and have less side effects. This is obviously a very important strategy if you're in a country where you haven't got a wide range of drugs available, or there's a financial restriction to access all the drugs. And the case that you've shown, which is essentially a pathway to stopping. So he was diagnosed, if I remember correctly, in 2021. Is
Yeah,
that correct?
it started 2021 June.
Sorry?
He started imatinib in 2021, and
Yeah,
now
okay. So he's obviously done very well. I mean, he got an incredibly deep response very early on. And that begs the question as to how long you should be on a TKI before you think about stopping. So you reduced him around about 3.5 years after he'd started, which probably for imatinib, most people would consider is too early to stop. I mean, the general feeling is probably you should be on imatinib around about 5 years before you stop. Of course, we have no idea whether people like your patient who do incredibly well, incredibly quickly, are different from the patients who perhaps take 18 months or 2 years to reach a DMR. So it's a bit of a moot point. So dose reducing him instead of stopping him is a safer thing to do, I think. And he was obviously very worried about stopping himself, so was more comfortable with the idea of dose reducing. When you have a patient like him who's been an incredibly good responder, so has very good biology disease, and his disease just melts away if he opens the imatinib bottle. The frequency of molecular monitoring I would use would essentially be the same as you would use routinely, so every 3 months. Now, you and he may be a bit nervous about that, so you might want in the first 6 months to do it every 2 months, but I think you'd be fine to do it every 3 months, and I'd be really surprised if the PCR goes up. In the Destiny study, we waited a year between dose reduction and stopping, and we only stopped patients who were in a good place after the year. So anybody whose PCR had risen in that first year of dose de-escalation, they were not offered the opportunity to stop. But in contrast to your patient, we dropped the dose by 50%. So we went from 400 to 200 of imatinib. You went from 400 to 300. So I think it wouldn't be unreasonable to give him 300 for 6 months and then drop him to 200 for 6 months and see what happens. Then it's up to you and him. He could go from 200 to complete stop. He may want to go through 100. That's a discussion you have to have with the patient. There's a lot of debate about the so-called Destiny approach, the dose reduction to before you stop, because I think that in general, people have become very relaxed about stopping, because if the patient has a molecular recurrence, you just put them back on the drug and they respond again. So lots of people say, well, why not just stop and try? Personally, I don't like that approach too much. I think you should try and be consistent with all your patients and have some kind of rules or guidance that you practice in your own hospital, so that you can compare what you're doing with the rest of the world. But I don't think he would need to go from 200 to 100. If he lost his deep molecular response on 300 or 200, I would simply put him back on 400 of imatinib. And then you could try a little later on. If you wanted to, you could try again. It rather depends on whether he's having a lot of side effects. So say you went from 300 to 200 and he lost his response, but he maintained it on 300. You could put him back on 300, see if he gets a response back, and just leave him on the 300. If you went from 200 to nothing and lost his response, you'd probably want to put him back on 400 for a little while and then dose reduce him at a later date. But all the time, you would be monitoring his PCR. So you would have some guidance as to the sense of what you were doing and whether it was safe, etc. And the frequency of monitoring during a treatment-free reduction, we are going to change this a little bit in the next ELN recommendations. So we're changing it to, there's still a bit of a debate about it, but instead of every month, we're moving it to 6 to 8 weeks, every 6 to 8 weeks in the first 6 months, and then probably 3 monthly thereafter. So we're becoming more relaxed about the monitoring, because we know that most patients will relapse, who are destined to relapse, will relapse in the first 6 months. And we know that they all go smoothly back into molecular remission once you restart the drug. So there's less pressure to catch the molecular recurrence in the first few days. There's some questions, I think, coming into the chat box. Is there a minimum dose of imatinib? That's a very good question. Is there a minimum dose of imatinib to do what exactly? To maintain a response or to get a deeper response? Difficult question to answer. If you have so there's two sorts of patients, right? There's a patient who is dose reducing on the way to stopping, in which case you're going through a program of gradual reduction and monitoring to see whether it's safe to stop. And there is the patient who probably has no chance of stopping, but has a lot of toxicity and wants to reduce that toxicity. And in that case, I think you just have to monitor them rigorously. So you could drop to 300 and see whether that maintains their response and gets rid of some of the side effects. You may be able to stop there. If they maintain their response but still have some side effects, you can go to 200. You just have to play around with the patient, the dose, and the monitoring very carefully. What you're after is maintaining a response that keeps the patient safe. Yeah, please do.
Yeah, so in the place where I work, India, and in other possibly low middle income countries, and Zeba and Professor Akhil, who both probably agree with me, there are two additional subsets of patients in which the half TKI or the destiny model we found to be particularly useful. The first is patients who are scared to stop the TKI. They know
Like
that they
him,
have
right?
a blood.
Yeah.
So, yeah. So they know that they have a blood cancer. They know that their disease is controlled. They know that they are doing well, and the group which have minimal toxicities. You give them this option that maybe we can stop your drug. They just get startled. No. I am doing fine. I don't want to stop it. So in those patients, to prevent long-term toxicity, if you offer them, okay, let's reduce your dose by 50%, do that for 1 full year, and if you stay in molecular remission, then we will stop your drug. So there, that is more agreeable and acceptable to them. And the second situation where I use the reduced TFR quite a lot is when I have a patient who at diagnosis has like very large disease bulk, which is not uncommon. Say, for example, a UTOS score of high risk. In that patient, I'm hesitant to stop the TKI. So I'm very comfortable in reducing the dose to 50%, whichever TKI the patient is taking. Try it for 12 months and then go in for the full TFR. So I don't know whether Zeba and Akhil agree with this, but these are the two specific subsets of patients in which half TKI really works for me. Over.
I just wanted to ask you one question. You talked about we talked about TFR, and we said we could cut the dose, and after a little while, you can try a TFR. I want to be very specific about how long after decreasing the dose should we attempt a TFR? Because that is a very important question, because there should be a minimum waiting time. Should we take it the same as if we have 2 or 3 consecutive RQ-PCRs which are negative before we attempt it? And there you say, okay, 3.5 years, 4 years with imatinib, 5 years, we should wait before we start an attempt on TFR. So here, after dose de-escalation, how much time should we give a patient on the decreased dose before we attempt a TFR?
Well, there are no hard and fast rules, Zeba.
Okay.
but in the Destiny study, it was a year
Okay.
between halving the dose and stopping. Now, Richard Clark, who was the principal investigator of Destiny, engaged a Department of Mathematics in Germany, I think. Might have been Austria, but I think Germany. And they modeled the kinetics of the PCRs between dose reduction and stopping. So over the 12 months, the patients had a PCR every month on 200 milligrams of imatinib. And what they showed was if the patient's PCR continued to go down in the first year, in that first year, it was very safe to stop them. If it went up, even though they might still have been in MR4 or MR3, it was not safe to stop them. And obviously the group that remained stable were a little bit in between. So I think what you would have to do is you would have to have 3 or 4 PCRs, at least probably 2 months apart, maybe 3 months apart, and look at the trajectory, look at the kinetics of the response. And if the PCR is okay, or it's even declining, then they stop at a year. I think it's just sort of common sense, really, to look at what the PCR is doing. If the PCR is starting to flick up, of course, even if they're still in a very good place, you know, they started in MR 4.5 and now they're in MR 4, you've got a hint that it's going up, right? So you wouldn't stop them.
Okay. So with reference to Heman's question, I think that we also decrease the dose when patients are intolerant, or if we know that this patient we are not going to attempt a TFR on, or if there's an older patient who we know has a limited lifespan. And there are a lot of patients who come to us with Parkinson's or coronary artery disease or others where they have multiple comorbidities and they are frail. In these patients, I think is one of the places where we like to start on a lower dose, and if they sort of tolerate it, we'll go higher up, but there's no need to. If the PCR is coming down and they're going to take it for whatever lifespan they have, which is 3 years, 4 years, 5 years, and we're not going to attempt TFR, a lower dose is equally right. Is that correct? Am I making sense?
I have another question to Jane. So Jane, tell me, if we start using the digital droplet PCR more frequently, then are we likely to reduce the number of TFR failures? Because it is quite devastating for the patient to, have a molecular relapse and restart the TKI. So if you look at molecular responses in an even more deep yardstick, then are we likely to reduce the number who fail over?
Do you mean look with a more sensitive technique, or do you mean look more frequently with your normal technique?
No, you evaluate, you assess by a more sensitive technique, say like the digital droplet PCR.
I don't know the answer to that question, Harant, and I'm not sure that it's terribly helpful, because the limits of the detection with digital droplet are, in most people's hands, a bit more sensitive than RT-qPCR. But once you get down to those levels, I don't know if that patient's a patient who's destined to have to lose MMR. I mean, you're using digital droplet to look at very, very tiny levels, right? I suppose if you were seeing a steady increase in the level, you probably wouldn't stop the patient. But I'm not sure in that situation where you've got a patient who's destined to relapse, that it's going to offer you much during the period of dose reduction. I mean, Philippe Rousselot may have some thoughts about this as well. We're very keen to to introduce much more sensitive techniques. But I'll go back to what I said earlier. People are very relaxed about stopping because if it doesn't work, you just put the patient back on the drug. So do you need to be spending a lot more money on the technology and the frequency?
Okay,
Yes,
point taken.
if I can just add a comment.
Please
We have
do.
looked on a patient that have been stopped based on PCR and the same patient based on digital PCR. And the end of the story is that if you look at the digital PCR, the percentage of patients that will be stopped is less, and the percentage of success is a little bit higher. So my conclusion is that if you have a very, very sensitive test to stop the patient, you will stop less patients with a higher rate of success. But at the end of the day, the overall results, the absolute results of patient of how many patients are effectively stopped is completely the same. So, and even though it could be less, because if you have less sensitive criteria, you will have the opportunity to stop more people, and perhaps overall, there will be an absolute number of patients that are in TFR a little bit higher if you are using too much sensitive testing. So I think is that what Jane said. It's not dangerous to stop people. You have to explain that it is a test to know if they are free from treatment, but if they are not, there is no problem to restart. And then you will offer the stop to more people and perhaps have an absolute number of people that are in true TFR a little bit higher in comparison with more sensitive tests, but much less people eligible.
I'm sorry to interrupt.
Philippe, can I just follow up for one moment on that and ask you very specifically, because you obviously were one of the first people to demonstrate that patients could lose MR5, MR4.5, MR4, but stay in MMR, right? So did everybody who it's a difficult way to phrase the question, but the group that you would have stopped by RT-PCR, but you wouldn't have stopped by digital PCR, did any of those remain in TFR?
Yes, of course. Yes,
Yeah.
of course. Most of those.
Yeah.
Okay.
So
and
So if you'd done it,
I'm
by
sorry, but I need to
digital, they
just
would have
change.
missed
In the interest of
chance.
time, we have to go to case 2. Otherwise, we'll never be able to finish the meeting. I'm so sorry, Jane and Philip.
Anyway, we should probably go.
It was such an interesting discussion. We'll go to case 2 now.
Okay, let me come back to my second case. This is a 72-year-old gentleman and experienced dull pain and discomfort in his lower chest in February 2019, and chronic chest iCMLf confirmed. His risk score was ELTS was intermediate, and though ELTS was low, the ELTS intermediate was probably for his age 72, and no additional congenital abnormality was found. Otherwise, healthy person with PCOG performance score 0. And imatinib initiated in February 20, 2019. Tolerated imatinib fared well, except few adverse events like recurrent mild lower lid edema. It was treated with diuretic successfully, and distressing pain in both nipple and early weeks of imatinib, treated with paracetamol and not recurred again, and mild to moderate anemia. Lowest hemoglobin was 8.4 gram per deciliter. Grade 2 neutropenia once, actually it was 1440 per cubic millimeter, and grade 1 thrombocytopenia once, it was lowest platelet was 88,000, and low grade cytopenia resolved and recurred several times. There may be some diet and drug interaction issue which could not be explored very well actually. Imatinib dose was reduced to 300 milligram for a short period of time once. For 1 month only. Hemoglobin was maintained within 9.5 to 10.5 gram per deciliter without any transfusion or erythropoietin stimulating agent. And he was again, hematological remission was achieved very early in 3 weeks only, though hydroxyurea was added in first week actually. And BCR-ABL1 was a bit irregularly monitored actually. Patient compliance was a bit poor. At 4 months, it was 0.089, and at 7 months, undetectable, but the lab was not showing any BCR ABL control copy, so could not be quantified actually. And at 11 months, it was major molecular remission, and 19 months, again major molecular remission. At 26 months, it was reported MR5, but again, lab was a bit issue. At 34 months, it was undetectable, but again, due to low ABL copy number, we could not call it. It is MR4 because it has ABL copy number should be at least 10,000. And at 42 months, again, it was MR5, and at 50 months, it was MR4.5, and at 60 months, TFR was attempted actually. And BCR ABL monitoring during TFR was not quite frequently as required. At 1.5 months, it was MR5 OL. At 5 months, it was only major molecular remission. At 6.5 months, again MR5, but it was a lab reliability issue actually. At 9 months, again it was MR4, and 12.5 months MR4. 16 months, MMR was maintained, but MR4 was lost. And at 19 months, finally, MMR was lost. And imatinib 400 milligram per day started once again, and after 3 months, he gained the MMR again. And question is, how to be the perfect time for dose de-escalation if planned to dose de-escalate now on MMR or after gaining deep molecular remission, considering the patient is quite older. He is now 76 actually. What would be the extent of dose de-escalation? Will it be a minimum effective dose to maintain MMR or to just maintain deep molecular remission? Will you proceed for the second TFR in this patient, provided the failing first TFR? And if second TFR is considered, is imatinib to be continued in deep molecular remission again, or to be changed to a second TFR? Discussion, please.
Thank you very much. Another nice case demonstrating some slightly different problems. And I think probably we ought to keep this brief so that we don't interfere with the next presentation. So this the first thing I'm going to do is answer your last question. Should we continue the imatinib or change to a second generation drug? Personally, I would not do that. You have a man who's now well in his 70s, right? Because he was 72 when he presented. So now he's something like 78, if I did the calculations correctly. He's got comorbidities. And so if you were going to change him to another drug, I think you wouldn't want to give him nilotinib because of the cardiovascular problems. And you probably wouldn't want to give somebody approaching 80 dasatinib. I don't know what other drugs you have available, and my guess is you don't have asciminib as second line, so I would not attempt to change him, particularly as actually he's really responsive to imatinib, so there's no indication to give him something else. I would probably consolidate him a little while longer. I'd probably try to get him back to MR4 at least before I dose reduced. And then I'd dose reduce very gently and just monitor him rigorously to make sure that I'm doing the right thing. The minimum effective dose to maintain MMR or MR4 is going to be completely patient dependent. It's not going to be the same for every patient.
What would be the target actually? Minimum effective dose, or if suppose if we maintain deep molecular remission even with 200 milligram dose, can we plan one more TFR once again? Because the TFR was not very short. It was more than 1 year, though it was shorter than 2 years.
I don't think any of us could hear you very well, but I think the question was around, could we, if we got him back into a deep response, could you try to stop again?
Yeah, exactly.
So
200 with 200 milligram deep MR.
I still did anybody else get the question?
So I think, Jane, what Professor Akhil is wanting,
I'd just leave him on that.
What Professor Akhil is wanting to know is that should we give 400? Should we give 200? And if the patient has a deep molecular response at 200, should we try to stop, do a second TFR, or continue on 200 only?
Okay.
Exactly,
I
sir,
got
exactly.
that's a bit of the question I got. Well, again, I think that's the sort of thing you would discuss with the patient because he's now 78. You're going to put him back on 400 milligrams of imatinib for 6 months or a year, and then you're going to gradually dose reduce him. So by the time you're thinking about stopping, he's going to be in his 80s. Now, it may be valuable for him because he got 18 months off the drug the first time.
Yeah,
It may be valuable for him to have 18 months of better quality of life, but I think the expectation would probably be that he would have molecular recurrence. So it's something to discuss with the patient.
I think if the patient does not have any side effects from therapy and he's doing well with it, why subject him to another TFR unless he wants to get it done? Because
except mild anemia. He had hemoglobin a bit in the lower range.
yeah, but he's
9.56.
76. He's probably not walking that much. And
Yeah,
why
yeah.
can't we leave him alone at this dose and continue with him and have a molecular response or a cytogenetic response and continue it till whenever?
I actually
I don't know. Did he
agree
feel
with
great
Deva.
off the drug? Because the other interesting thing is when Efficace did the quality of life assessment on patients who were older who stopped the drug, they didn't really get better quality of life because they had so many other comorbidities that they were still impacted by those, irrespective of what was happening on the TKI. So there may be no point in stopping, but discuss with the patient.
So I think there are a couple of questions in the chat box which Jane might want to address. One question is the question which everybody asked before a TFR is the minimum duration of imatinib exposure. Should it be 5 years before considering a TFR, or can you play around with that?
Well, I tried to answer this before. The vast majority of data we have on stopping is generated from patients who stopped on imatinib. The numbers who stopped after a second generation drug are increasing, but the vast majority in the literature are people who stopped on imatinib. And there seems to be a very clear association with the duration of the TKI exposure or the duration of the deep response and the success rate. It varies a little bit between papers, but there's definitely a trend towards the longer you're on the drug and the longer you've had a deep response, the more likely you are to be able to stop, which kind of makes sense, I think.
One,
Nobody knows for an individual patient how long they should be on the drug. I mean, your first guy was essentially in MR 4.5 at a year, I think. So maybe he doesn't need that long. But somebody who's much slower to respond probably needs a lot longer because there's at least 3 slopes to the curves when you start somebody on one of these drugs. So if 3 slopes to the PCR curve. So there's a very precipitous drop as they respond initially, and then there's a slowing of the curve as they start to get down to MR4, MR 4.5, and then there's probably an even slower slope with gradual attrition of all available leukemic cells until at some point you get to the position that you can stop. And the longer you're on a drug, the better. But because we have drugs that induce remission much faster, the push now is to stop much earlier. But that's largely after upfront treatment with a second generation drug. Again, Philippe's had a lot of experience, so he may want to make a comment.
Yes, perhaps a comment, because by knowledge, there is no formal demonstration that a shorter duration with second generation TKI is of importance as compared to a longer duration with imatinib. There is no formal and prospective demonstration of that. And I think we have to keep in mind that the duration of treatment is an independent factor, prognostic factor, compared to the duration of the deep response. So there are two factors that are independent and that we have to deal with independently. And so I will be quite conservative in that setting. I will just try to give the patient imatinib at least 5 years. And in most of the stop studies that have been published in France, the median duration of imatinib was up to 8 years. So it was a little bit longer than the recommended duration. So I completely agree with Jane. The longer you are treated, the better you will have a nice TFR on the long run.
Thank you, everybody. I think in the interest of time, we'll have to start on the second session. Otherwise, we'll never be able to complete our second session.